We are live.
Yeah. Hi, everybody. Welcome for this masterclass on a Saturday night. I know everyone is busy with the IPL match, but we thought this topic is so very important to be discussed, and we want to, I think, do this very important topic today, even though everyone is busy. Dr. Aarti is coming back from a very important meeting, and Dr. Jay just finished sigmoid resection, which he took like probably 20 minutes. So today's topic is the importance of endomyometrial junction in cases of adenomyosis. So this has been spoken for many times about what is the most important criteria that we look for when we tell them the fertility outcome in cases of adenomyosis, like before treatment, after treatment, during surgery, especially. What is the one important thing that we all look for is the endomyometrial junction. I think this is one of the important factors, and the others being the size of the uterus, the symptoms, and all the other coexisting factors. And this is special class because this topic per se specifically has not been dealt as a single class. So this, I think we receive so many queries on endomyometrial junction and its importance in adenomyosis. I think today's class will give a lot of insight as to what is the importance, how do we look for it in treatment, what is it that we want to change, like in endometrial thickness, endometrial junction, which will be spoken by Dr. J, because we have treated many cases where there is alteration in the endomyometrial junction, and then we have counseled the patients in a certain way. Yes, over to you, please.
So, hi everyone. I'll be just sharing the screen. Fine. I think you can see my screen, right?
Yes.
Okay. So, see, when I draw a typical uterus with adenomyosis, okay, this is typically what is going to happen as far as the endometrium is concerned. Now, what is important for us to understand is that whenever we are trying to look at endomyometrial junction, okay, the endomyometrial junction which we see is basically a representation of how good the ecotexture of endometrium is. Why did I say this is very important? This is because if you have a damaged endomyometrial junction, this endomyometrial junction is going to be predominantly damaged along the posterior aspect. It is going to be damaged along the fundal aspect, and it may be damaged at multiple places. All right. This damaged endometrial myometrial junction is one of the markers of chronic endometritis, and along with chronic endometritis, it is also a marker for adenomyosis. Okay. Now, when we try, now when we try and speak of endometritis and adenomyosis, we should try and understand and remember one very important thing as far as this is concerned, that this gives rise to something called as lack of triple line. Okay, so whenever we are studying the endometrium for the patient, and if you have a presence of loss of EMJ, endomyometrial junction, basically it indicates a poor outcome. Now, why is there a poor outcome? And first of all, why is it that there is a loss of endomyometrial junction? Okay, this endomyometrial junction is predominantly mediated by estrogen beta receptors. This estrogen beta receptors then gives rise to a high amount of inflammation, as we have studied in our previous classes. This inflammation then gives rise to increased activity of NK cells. These NK cells are basically peripheral NK cells. As we know, the ratio of uterine NK cells goes down drastically. That is also being studied as a part of our masterclass in endometriosis. And because of this increased peripheral NK cells, there is going to be a lot of cytogenic activity, which is going to cause the basal endometrium to get distorted. Some places where the basal endometrium gets distorted, the endometrium then begins to grow inside the myometrium. And when the endometrium begins to grow inside the myometrium and starts percolating in a linear manner inside the myometrium, the reason why it percolates in a linear manner is because of the crisscross arrangements of fibers of the uterus. And as a result of this, what typically happens is that this crisscross arrangements gets broken, and this gives rise to something which is very typical, which is called as the sunray appearance as far as the endometriosis and adenomyosis is concerned. Now, whenever you have a loss of endomyometrial junction, what are the particular aspects, after understanding this theory, what are the particular aspects which you as a doctor should be taking care of in order to make sure that there is going to be some fertility benefit which the patient can encounter? Okay, remember, we have already mentioned that the fertility benefit to these guys is going to be extremely poor. But if in case we are to benefit these patients in any manner, then you need to make sure that the endomyometrial junction gets healed as close to the endomyometrial junction as much as possible. One of the only methods in which you will be able to heal this, actually, from what we have studied, and that is our early data, after our first patient, after our first paper gets published, we will be publishing this for sure, and that is a gross improvement in endomyometrial junction after doing microwave ablation of adenomyosis. Okay, we have seen this in a lot of patients. In fact, what we have come to a conclusion is that majority of the times our fertility rates after microwave ablation has shot up so drastically, even for natural intercourse, is predominantly because the endomyometrial junction has improved. Only when the endometrial myometrial junction improves, okay, there can be implantation. That is because you require uterine NK cells to maintain implantation. I have some small stupid theory probably which tells us why does this endomyometrial junction improve after doing microwave ablation. The reason why it improves is, see, there is some amount of heat dissipation which occurs from the microwave ablation probe. I don't know how many of you have seen a live microwave ablation which we have done. So we have demonstrated around 40 of them so far on Facebook and Instagram. But we have done many at Dr. Arti's place and Dr. Shilpa's place. And what typically happens is, on ultrasound, you will see that there is radiant heat which glows away from the probe. This radiant heat goes towards the serosa as well as towards the endometrium. And when it goes predominantly towards the endometrium, what it does is that we try to limit it at approximately 0.5 centimeters away from the endometrium. When it goes till that particular junction, what it does is it causes destruction of that entire cells of adenomyosis which have reached till there. As a result of this, they undergo coagulative necrosis. Once they undergo coagulative necrosis, they are simply shed out, okay, or they are getting absorbed. In the process of getting absorbed, there is inflammation. And in this process of inflammation, there is some amount of remodeling which occurs to the uterine endomyometrial junction. And this grossly improves the outcome for the patient. The other method of checking a loss of endomyometrial junction, apart from doing an ultrasound, is by doing a hysteroscopy. And on the hysteroscopy, on the posterior aspect of the uterine endometrium, posterior wall, you are going to be seeing spots. And these are the spots of adenomyosis which are going to be clearly visible. And they are another significant marker for having an extremely poor fertility outcome in this. Now, how is this important as compared to our traditional methods? We all know that when you try to look at the traditional methods of getting a volume reduction for the uterus done, that is either in the form of giving lupride depot or any form of GnRH agonist depot. What typically happens in a GnRH agonist depot is that there is severe downregulation of the existent endometrial receptors. These existent endometrial receptors will only be downregulated and they will prevent further development of adenomyosis from occurring. But the basal break, which has already occurred, will continue to stay because the fibers of adenomyosis which have crisscrossed the uterine myometrium, they are never going to be healed. And because they are never going to be healed, despite giving GnRH agonist, many occasions you are going to be observing that despite your best possible efforts, okay, the patient is not going to be having any benefit in endomyometrial junction. These are another set of cases where using microwave ablation very effectively, very prudently is going to give your patients a gross benefit as far as fertility outcomes and improvement of EMJ is concerned. This lecture I'm going to limit only to loss of endomyometrial junction in endometriosis and adenomyosis. It can also get lost in two other cases. Predominantly in India is tuberculosis. Tuberculosis is another form of chronic endometritis which occurs in the endometrium. That is something which is very bad. Of course, we all know that it is virtually irreversible. The reason why it is irreversible is what you should understand, because it causes loss of endomyometrial junction throughout the endomyometrial junction. Adenomyosis is lucky because it will cause loss of endomyometrial junction only at places where adenomyosis is present. If you have anterior adenomyoma, it will be anterior. If you have fundal, it will be fundal. If it will be diffuse, it will be at multiple spots. If it is posterior, it will be at posterior. And the second thing where there is complete loss of endomyometrial junction is in cases of Asherman syndrome, that is predominantly after DNC. Endomyometrial junction is completely lost, and as a result of that fibrotic healing, you have a cavity which is completely empty. Both the cases, TB as well as cases of Asherman's, are extremely difficult to treat no matter what you do, despite doing the best hysteroscopy. Reverse outcomes you will get when you have adenomyosis. When you do this procedure, the EMJ will improve and the patient may experience fertility benefit. Okay. So with that, I stop and I'll be happy to answer 2 or 3 questions.
So, in our case selection, we check the size of the uterus, we check the location of the adenomyoma or adenomyosis, and also we tell them about the EMJ.
Yeah.
So, when there is a gross damage in the EMJ, or when we see that the triple line is not there, it is very thin, the endomyometrial junction is very ragged, when we check the vascularity, it is quite abnormal. So, in such cases, what do you think of the fertility outcome if you do the microwave ablation? I mean, how do you counsel in such cases? Do you go ahead and do the microwave ablation, or do you tell them that the chances of implantation will be very poor? What is it that you tell them?
It will improve, but it may continue to stay poor because uterine adenomyosis is not a permanent cure even with microwave ablation, right? But
Right.
definitely it will improve. We have seen, you remember that patient whom we had seen, and we had told them that no problem, next cycle go ahead and do the embryo transfer. I don't know what their outcomes are, but I know that that guy had no endomyometrial junction when we had done ablation for him, her. Okay. And when she came back to us after 2.5 to 3 months, there was a beautiful triple line in the endometrium,
Yeah,
isn't it?
yeah.
And that type of healing can only be possible with ablation, because in ablation you are able to go and do ablation at multiple locations along the posterior uterine wall. What
Mhm.
typically happens with traditional surgery also, what used to happen with adenomyomectomy, was that you were only able to go to a particular depth. You remember we used to never cut off that part close to the endometrium, and that would
Yeah.
continue to stay. So patient would have great pain benefit, but patient may or may not have similar benefit as far as fertility was concerned.
Yeah. So in such cases where the endomyometrial junction is altered, so that means that the adenomyosis is very close to the endometrium, isn't it? So
Yeah.
what is the cutoff that you take when you actually go and give the burst of the thermal energy in
zero point
such
0.5
case?
centimeters away from endometrium.
Okay. So the what is the lateral spread of this heat
It will depend, madam, on what type of, heat setting and how
setting
long
you
you are
have?
applying it for.
Yeah, yeah. So when you are doing it so close to the endometrium, do you always keep this under vision with either the transvaginal ultrasound? Don't laugh.
I try to, but then
It's good.
quite a lot of times we don't do it under ultrasound guidance, probably simply out of experience now.
Yeah, yeah. So the mapping, once it is done correctly, like how you do it.
Yeah.
So probably like because of the experience of doing so many cases. So what we usually do nowadays is just you map it in the beginning of the case, and you know exactly like where to poke
Yeah,
and how
and
many.
usually the endometrium is never even damaged.
Yes,
So it is
yes.
a mental map which we try to make, just a random mental map. If you see, what I try to do is I try to calculate the distance of the endometrium away from the serosa, right?
Hmm.
How much length it is, 3 centimeter, 5 centimeter, 4 centimeter, like that. And then
Correct.
when I put the ablation probe, I actually put 3 centimeters, 2 centimeters, 1 centimeters, whatever. And that is
Yeah.
something which may benefit.
Okay, let's talk about it in a different way. So, see, if the adenomyosis or like the patients who come to us, one is the symptomatic with severe pain, who are like I mean, extremely having poor quality of life. The other set is the fertility patients who have multiple embryo transfers failed or recurrent miscarriages, multiple biochemical pregnancies. So if we think of it the other way, so we sometimes we tell them that, oh, your endometrium is not good. Should we really go and do the microwave ablation? I mean, initially, I mean, I used to think like that. I mean, it is any which way is not good. So is it really going to help if she is not symptomatically affected by the adenomyosis?
Absolutely. In fact,
Yeah,
now it is the exact reverse.
exact reverse, isn't it?
Yeah,
Yeah, that's what we saw.
even if the patient is asymptomatic but has a bad endomyometrial junction, I would want to go ahead and ablate, because I know that the possibility of giving her a good endometrium will improve
Yes.
at least in 50% of these patients.
Yeah, yeah. I totally agree with this point because I mean I never used to believe this when we actually started the microwave ablation probably like 8 months back. But now after seeing so many who come for follow up, I mean they have beautiful triple line, beautiful. I mean it is like unbelievable
You any
actually.
which ways don't believe many things which I say, madam. That is the problem. You realize only late, after 2 3 months, what to do.
I know. I'm sorry. So I think this is one of the very important factors where the microwave ablation scores over the conventional adenomyomectomy because we used to struggle to remove the adenomyomas and also the diffuse adenomyotic tissues from the all walls of the uterus without actually touching the endometrium. And we were never successful in probably giving them the best outcome. But microwave ablation, in fact, has, I think, a good advantage over the surgery with regard to preserving the triple line and also preserving the endometrium. But tell me, I mean, when you say that, like, the damaged endomyometrial junction, you want to do microwave ablation, and when there is no triple line, people go and do hysteroscopy. So apart from chronic endometritis and tubercular endometritis and Asherman's, how is an hysteroscopy going to help in adenomyosis cases where there is no triple line? What is your thought? What they should look for?
No, no, they should not look for anything, because it is not going to help you in any manner. The sonography these days is so good, no, madam. If you do a 3D on even our type of machines, see, we don't possess machines like how Aarti madam has, but even on regular ultrasound machines, if you map the endometrium on 3D, you will identify the EMJ breaks very
Yeah.
nicely. So you need not do a hysteroscopy just to identify the EMJ breaks. You can do a hysteroscopy after you have done ablation to find out what is the situation of the endometrium. Apart from that, nothing else is required.
Yeah, yeah, yeah. That's a good point. I mean, but see, you see some blebs in adenomyosis, you see some adenomyotic, like, cystic spaces on the endometrium on hysteroscopy, which have been done, like, multiple times. A hysteroscopy has been done in cases of adenomyosis because many people are like clueless as to how to do either adenomyomectomy or they don't believe in it and they keep giving lupride or, sorry, GnRH agonists or any kind of other medications which can be an alternative for surgery is what they think. So these routine hysteroscopies, what do you think their role is in terms of like, I mean, as a plan of treatment or like in telling them about the prognosis?
I personally think in today's time and age, if you are doing pre-IVF hysteroscopy under general anesthesia, that is probably not good. You want to do pre-IVF hysteroscopy, you can do it as an office-based procedure under local anesthesia, so patient does not have to waste that time, just in case you want to do it, right? If in case you don't want to do it, it is completely fine. I mean, it's not going to be that you have not done a pre-IVF hysteroscopy and then something grossly wrong has happened, right? See, sometimes it can be a money spinner by adding that 10 15,000 rupees, it is out of package for the patient, and then you are doing a pre-IVF hysteroscopy stating that it may improve outcomes. Maybe a desperate patient will just say yes to everything, but I personally don't think that's how it is.
Yeah, yeah. Thank you very much. So, Dr. Aarti, do you have any questions? We have Dr. Mamta
Yeah.
Madam here with us today. Madam is a pioneer in doing ultrasounds and identifying the defective endomyometrial junctions all through her life. And
She
she has
just
prepared.
got down, Shilpa. So she's not
Oh,
there
I'm
next to
so
me, but
sorry.
she heard the whole session. And Jay, I just have one comment to make. So you mentioned that breaks in the endomyometrial junction is indicative of adenomyosis, and other DDs were mentioned, and that lupride and adenomyomectomy is not going to offer the advantage like how microwave offers the advantage of remodeling. And you mentioned that, I mean, all of us have seen improvement in the junctional zone and the triple line appearance. So my question is, how long does it take for this remodeling to happen? And when can we start observing this improvement in the junctional zone? And
After
when
2
we see
months.
the so 2 months. So when we see this, it's not going to happen in every patient, but you mentioned it at least happens in about 50% of patients.
Yeah.
So when we see this improvement in the junctional zone, maybe these are the patients who are at a better chance of getting pregnant naturally, provided, of course, their tubes are okay. So
Absolutely.
this is an indication. When you see an improvement in the triple line appearance in the junctional zone, you know that these are the ones who most probably will conceive naturally.
Absolutely.
Okay. Okay. And any particular group of patients you don't actually see so much of an improvement in, like a very large size uterus, or if there is associated endometritis or tuberculosis along with adenomyosis, so you see lots of uterine endometrial buds, any particular patient you don't see an improvement in, Jay?
Difficult to predict that, ma'am. Approximately 40 to 50% of the patients may not improve.
Okay, so there is no criteria where you know that these are the ones who are really not going to improve, like very
Yeah.
large uteri.
Nothing like
Because
that.
we have seen patients with associated, tuberculosis or chronic endometritis. These are the ones who maybe don't improve so much post
TB is
ablation.
bad only, no, ma'am. That's what I was saying. TB is bad any which ways.
Right. Okay. So I think I'm done. Very, very wonderful points to take home, Jay. Thanks, Shilpa.
Thank you, everyone.